Good afternoon, everyone, and excited to welcome Luis Argueso, partner at InHealth Advisors. Luis, I was hoping we could start with a quick introduction on your end, and then I'll kind of kick us off on the topic today.
Yeah, absolutely. My name's Luis Argueso. I'm partner and co-founder of InHealth Advisors. We are a advisory firm that assists organizations tackling the challenges related to value-based care, with a particular emphasis on provider alignment and engagement with value-based care initiatives. So how do we appropriately incentivize our provider partners, our provider employees? How do we develop contractual and partnership models that make sure we're all pulling in the same direction when we are essentially having to adopt the risk of controlling care costs and delivering higher quality care.
Great. And so we brought you on today because you're the perfect guest to talk about this, but the Medicare Physician Fee Schedule was released on Halloween. It finalized something called the Ambulatory Specialty Model, which is another one of these new mandatory models from CMMI that is focused on specialty doctors. And so with that, I was hoping, could you kind of kick us off and talk a little bit about what the program mechanics are, who does it apply to, and what do they have to do?
Absolutely. I'd love to talk about the program. I have some visuals to help us kind of ingest the information because it's a lot. I think it ended up being uh, 200 to 400 pages within the actual final rule. But it is a very interesting model. In brief, the ambulatory specialty model, which was finalized in the 2026 final rule, creates a new mandatory value-based payment program for providers that are treating two specific conditions, low back pain and heart failure. And so we'll talk a little bit more about the details of the model, but I do want to emphasize a couple of things about it. The model is mandatory. It's going to be mandatory. They're going to use a statistical sampling method similar to what they used with the team model in order to identify who those mandatory participants are. But essentially, the way to think about it is as kind of as much of a randomized controlled sample as you can do in the health contracting world to test out exposing providers to greater levels of upside and downside risk in reimbursement based on their ability to manage care costs as well as deliver higher quality care.
Great.
So,
And
yep.
yeah, I think I was just gonna ask you what specifically is covered by it, but I think that's where you were headed anyways.
Yep. Great question. So bear with me a second here. I'm going to flip over to some visuals. I thought it would be helpful for us to um, take a look at some of the resources that Medicare has hopefully prepared for us. So let's start at the top, which is what is the who are the participants in the model and what is affected by the model. So the ambulatory specialty model applies to providers that have a minimum of 20 Medicare patients, and they say original Medicare, traditional Medicare. Basically, these are non-Medicare Advantage patients. So in order to be eligible, you have to have at least 20 patients that qualify based on a diagnosis, and you have to be one of the affected medical specialties. So on this slide here, we show a little bit more about the affected specialties. The two types of episodes that they're tracking are low back pain and heart failure. For heart failure, it's pretty easy. If you have the specialty code for cardiology and you have 20 original Medicare patients that have been diagnosed with heart failure and you're one of the mandatory required participants, you are in the model. For low back pain, it's a little more broad-based and frankly, in my opinion, quite interesting. It covers a wide range of specialties, folks that you would normally think of treating low back pain, like pain management physicians, but it also covers neurosurgeons, orthopedic surgeons, providers that typically treat these services on a surgical basis, procedural basis, surgical as opposed to a procedural basis. So real interesting kind of selection there. And the way that the model works is you have to be in one of the mandatory markets. You have to have the specialty codes for the specialty that's listed here, and you have to have the 20 original Medicare patients that have a qualifying episode there. So that's who's in the model. Let's talk then a little bit about how the payment works. And if I miss any kind of the key items, Martin, please interrupt me and let me know, and I'm happy to talk
Of
about a
course.
little bit more about
Yeah.
that. But how does payment work? And this is where things get really interesting. The way that I would summarize this payment model in a couple words is basically the MIPS program on steroids, where it is looking to increase the magnitude of how your Medicare reimbursement is affected based on your performance in the MIPS value pathways, which they refer to as the MVPs, which we'll talk about a little later. But basically, the way the model is going to work is it's going to have an up and down adjustment to all Part B reimbursement. So it's not just the reimbursement that affects the at least 20 patients, original Medicare patients that are eligible for the program. As soon as you meet the eligibility criteria, the payment adjustment is going to apply to all traditional Medicare Part B revenue. So this can have a really substantial impact on your reimbursement if you see a lot of Medicare patients, which based on the diagnoses that were targeted, you likely do. So the risk levels that are shown on this table here are basically the maximum potential upside or downside adjustment to your Medicare reimbursement. And so historically, MIPS has provided a little bit of a upside downside adjustment, but not real substantial. Here, we're starting to get into real substantial territory where we're looking at a range from somewhere from an up or down 9% adjustment to an up or down 12% adjustment, again, on Medicare Part B, traditional Medicare patient reimbursement. The way that reimbursement adjustment happens is based on a score. You're eligible to receive a score from 0 to 100. So the chart that you see on the screen kind of shows the potential range of scores, and it also shows how they've decided to model the reimbursement adjustment. They're using this logistic exchange function, which basically the way to think about it in simple terms is you're graded on a curve. And most of the people are going to fall in the B, C, D range, with a few folks falling in the A range, where they're going to have a really significant positive upwards reimbursement adjustment, and a good chunk of folks falling in the or a smaller chunk of folks falling in the F range. But it's kind of an equal distribution across the scores, which is a little different than how MIPS worked. MIPS is a little more complicated, and folks can read into how that reimbursement structure works. But basically, what we're looking at here is kind of like a symmetrical upside downside model, which Medicare was very eager to push because they want to see more two-sided risk, and they want the amount of reimbursement at risk to be more significant.
Luis, I feel like some criticisms of these models in the past or CMMI in the past was that number one, that there was only upside risk or that there was not sort of sufficient stakes. And then another kind of criticism was, another criticism was they weren't mandatory. And then another one was that it wasn't zero sum, right? Like that it ended up costing money because you're sort of giving incentives to a lot of people. So it feels like this model addresses sort of all three of those criticisms.
Exactly. It's got upside and downside. The magnitude of the upside and downside is pretty material, unlike it had been in the past with MIPS. It is a mandatory model, so you don't have, well, I've done the analysis and I know I'm going to do well, so I'll opt into the model, or I've done the analysis and I'm going to do poorly, so I'm going to opt out. You don't have that adverse selection issue, and it's really trying to create a symmetrical framework in which you've got half of the folks that are seeing reimbursement decreases, half of the folks that are seeing reimbursement increases. So, and I should add that basically the way that you're assigned points is based on your decile performance in the MIPS value pathways measures. So, you're graded, you truly are graded on a curve. If you're in the top decile, you'll get the full 10 points. If you're in the bottom decile, you're not getting any points. So, it's really aggressive. It aligns too with kind of the Centers for Medicare and Medicaid Innovation, their goal of having more upside downside models where it's not upside only, as well as trying to kind of bend the cost curve, as well as the focus here on the conditions is really interesting. It's kind of a new approach. It aligns that kind of piece aligns with more of the wider MAHA, Make America Healthy Again agenda, where they're trying to target chronic conditions and really affect the cost curve earlier on in terms of the intervention, the scale of intervention, like try to avoid hospital admissions, try to avoid ED utilization. So it's hitting on all the kind of goals that the Medicare program has.
Cool. Maybe you're going to get into this next, and so I don't want to sort of step on your shoes here, but I am curious what it'll look like for a physician who's a mandatory participant.
Yeah, I think that's a great question. So what's kind of like the magnitude of the impact of this program? And I thought it'd be helpful to have a little bit of a summary table here that gives folks a sense of what that might look like. This is real simple high level math, but the short answer to the question is it kind of depends. There's a wide range of potential impact, and it really what's going to drive things is how much of your patient base is within traditional Medicare. So what I've done here is I've tried to model what I think are some low, medium, high impact providers to give folks a sense of like, okay, well, what are we talking about in terms of magnitude of dollars? So this table here provides a kind of range of collections benchmarks. And the model example that we're using here is cardiology. So it provides a range of collections benchmarks from the 25th percentile to the 75th percentile using some of the survey data sources we know and love, AMGA and MGMA in this case, for cardiology. This is non-invasive cardiology. And so there is wide variability in reimbursement amongst amongst cardiologists, a lot of it having to do with the payer mix, but a lot of it too also having to do with the amount of patients that these providers treat. And so we did a couple of scenarios where we looked at, okay, how much of my collections is represented by traditional Medicare, ranging it from 20% to 60%. That's a pretty good range in terms of capturing what we see out there in the marketplace, which gives us then an estimate of Medicare revenue. And then when we apply the ambulatory specialty model payment adjustment numbers, we get kind of a plus minus impact. So on the low end of the spectrum, you're not really affected too much by this model. You're looking at somewhere in the neighborhood of an $8,000 plus or minus impact. In the medium end, which is where I expect most providers to land, we're starting to talk about a little bit more of a material dollar number here in terms of a potential plus 25,000, minus 25,000 swing. And there's going to be a subset segment of the market where you have really high volume cardiologists that are seeing a lot of Medicare patients that are going to see a pretty significant potential payment impact. We're talking a $65,000 plus minus, which ends up being a $130,000 swing. And it's those providers that I think will want to pay particular attention to this model because it's going to really impact their reimbursement.
Got it. So in terms of total collections, I was just doing the numbers off to the side, but that's, the $25,000 at stake is roughly 4% of collections for that doctor in the medium category. And in the high category, it's 7% of all collections. Like that's a pretty big,
Yeah,
it's not nothing.
Yeah, it's not nothing. Like it's one of those numbers where it's like, it's basically your margin. You can think of it as your margin, right? It's like how much of a distribution am I taking home as a provider from the work that I'm doing? So that's the way I think about it. It's enough to affect behavior, I think, at the margin, but not enough that you're going to change entirely the way that you practice medicine in order to adapt to this model.
I think that's a great way to think about it. And I think that, I think that's like that chart was pretty intuitive for me. Can you kind of talk about what being successful in the model is going to look like?
Absolutely. And let me pull back up my video here. So, I'm really happy to and glad to be talking about it in the forum of health tech nerds in particular, because I think there is a lot of opportunity for technology to drive success in this model. I think Medicare has highlighted a couple of key areas, and just based on my work, I think there's a couple of other areas to talk about in terms of success drivers. The first thing is, and this is what from the folks that I've talked to, kind of Medicare's new philosophy in terms of value-based care is interoperability and familiarity with electronic health records and the application of data from EHRs into your practice of medicine is now table stakes. You have to have capabilities within those domains, and Medicare's, I think, philosophy is there are a lot of solutions out there that can do this for you. You can do it internally as a group, but at this point in time, you should know how to use EHR data to drive better outcomes, and you should have some sort of interoperable framework where if you're a specialist and you need to find alternative care pathways to procedural or surgical work, you have those relationships with PCPs, or you have those relationships with physical therapists in the case of low back pain to help manage some of these conditions in a low-cost way. So philosophically speaking, if you are a practice and you're going to be heavily impacted by this model and you don't have a lot of facility with EHRs and interoperability, and that's something that you're going to need to develop sooner rather than later. I should mention that the model goes into effect in 2027, so you do have a year to get there, fortunately. But it's no longer going to be the case that, well, if you do really well with the interoperability, we're going to give you a reimbursement boost. If not, you'll get a modest penalty. No, it's pure penalty if you don't demonstrate interoperability, if you're not engaging in their promoting improvement activities. So that's key piece one, and there's a lot of neat data tools out there that I'm sure a lot of vendors who are members of Health Tech Nerds would be happy to kind of promote amongst folks listening. The other piece that I think is really important to establish within this model, and this is one that Medicare really highlighted, is what they refer to as collaborative care. The other terminology that we see used is care coordination, but really it is the ability to exit the traditional kind of medical silo that has existed within specialties and work together with other types of providers. When you look at the particular conditions that were targeted as part of this model, it becomes really clear that you need to develop relationships with other complementary service delivery partners. So in the case of low back pain, I mentioned physical therapy as a perfect example of, look, if you're going to be judged based on how well you're controlling cost, you want to, for those patients where it's clinically appropriate, send them to PT first before adopting a procedure or surgical first type of treatment pathway for those patients. So developing those partnerships are going to be essential. Medicare even kind of referenced folks pursuing collaborative care agreements, which is something that I know they promoted within the Medicare Shared Savings Program. But I think the way to think about it is if you're not already in an integrated delivery system, or even if you don't have clear care pathways that identify from a clinical perspective, risk stratify patients and identify appropriate interventions based on the patients. If you don't have that capability in place, you want to develop that capability. I think as well, it also forces providers to, and this comes from the work that we do, it forces providers to think outside of the box, the typical box of fee-for-service medicine. If I'm a cardiologist and I've got a patient with heart failure, the only way that I used to get paid, and even unfortunately under this model, the way that I still get paid is based on bringing that patient to the office, having a visit, being able to drop a CPT code and get fee-for-service reimbursement. What this model is doing, though, is it's starting to shift the incentives a little more to say, on the margin, is the right pathway for me to bring this patient into my office, or is there perhaps a remote patient monitoring or chronic care management program that may make sense for this patient that doesn't require them to have to come into the office and me drop a higher level E&M code as opposed to billing a lower cost RPM or CCM service level. So really thinking about how you have the incentive structure set up for providers within a practice. If you're paying purely based on work RVUs, you really have to evaluate and think, what impact is that going to have on this model? Is it going to drive your cost above your peers? Those sorts of things I think are really important drivers of success.
My intuition would be that, you and I both have spent some time in Colorado, and so, like a UC Health, like a large integrated network, which has physical therapy as part of the network and has, folks out in the community and primary care is like really well positioned for something like this. It's an integrated clinical network that
Yeah.
has all of those assets. If I'm like an individual cardiology doctor or back pain person, that seems like it's like a sort of whole different ball game for me. I'm curious if you have any examples or have worked with anyone who is coming from that sort of smaller provider group, how they might interact with a model like this.
Yeah, absolutely. And I would say, I don't want to be too salesy here, but part of our core business is helping organizations take advantage of a lot of new regulatory flexibilities that were specifically designed for your non-integrated delivery network providers. So it used to be the case in the past that if you weren't attached to a UC Health, you had to pay full freight on EHRs, and that could be incredibly costly. If you wanted to develop care navigation, you as a practice had to kind of foot the full bill for those sorts of resources, or sign on to an organization like an Aledade or Pearl Health, a value-based enablement type platform that could bring those capabilities to the table for you as an organization. I do want to point out, and it's really important for independent providers to acknowledge that there have been new regulatory flexibilities that enable those types of practices to enter into arrangements that historically in the past would have been potential compliance landmines from a Stark and anti-kickback statute standpoint. But where now you have the ability to do things like share discounted resources between groups. So let me give an example that actually ties well
Yeah.
into this model in particular. We worked with and this was really fascinating because it was not a small practice, it was a big practice, but they operated in multiple small communities in a rural component of a state, and they were pain management focused. And one of the big problems that they had was they had a patient population that two things. Number one, they did not have good connectivity from a just a raw internet standpoint. And two, they had a really big lack of access to care. And three, there was prevalence of opioid use disorder in the community. And so you think about that practice and you say, well, what can they do other than align with some sort of integrated delivery network? But what this practice did and enabled them to kind of stay independent was they formed what's referred to as a value-based enterprise with a behavioral health practice, where basically what they did was they had their nursing staff facilitate a telemedicine visit with a behavioral health provider that would provide the necessary screening of those patients to evaluate if they were eligible for pain medicine procedures like radiofrequency ablation, while also doing things like collecting key quality data. Like they were screening these patients to determine if they had an untreated substance use disorder, and then would be able to get them referred into substance use treatment plans appropriately. The problem in the past was if all of that was getting facilitated within the pain medicine practice, and that behavioral health provider had the ability to refer that patient for pain medicine services to that practice, that's a huge no-no. You are giving a free benefit to the behavioral health practice that then is potentially generating referrals for you. But what the value-based enterprise framework does is it enables that type of relationship so long as the parties that are involved are advancing legitimate value-based purposes. And so this group in the behavioral health practice set up this formal monitoring program that, as part of the process, they were administering standardized questionnaires to be able to assess substance use disorder, substance use risk for these patients, and ensure that if any of those high-risk patients were identified, they could refer them to appropriate care resources to treat that and kind of advanced value-based care while also like supporting the underlying business of the pain medicine practice, which really did need to make sure that those patients were getting that behavioral health screening, but they didn't have access to it in the communities they were in.
It's a really interesting example, I think, in the context of what's going on with the Rural Health Transformation Program as well, is that, there's this like transformative, these CMS is thinking about this as a transformative grant program, and then you have CMS also doing these models, which, they do have some benefits for an integrated delivery network, but also you can kind of stitch together your own integrated delivery network if you're in a rural area or you are independent.
Yeah, and I think my background is in economics, and I really got into healthcare around the time that the Affordable Care Act passed. And the thing that I saw as part of it was there's a lot of great parts of it, but with the push to EHRs, it was increasing essentially the barriers to entry into healthcare. You really had to have access to resources to build out an EHR. If you were trying to get involved with an ACO, you had to have the resources able to fund care navigators, that sort of thing. The unfortunately, in the rural settings, you got a double hit. Number one, your payer mix wasn't great, so you didn't necessarily have that resource base that allowed you to meet those barriers to entry. And number two, you had all sorts of challenges with access. Did you have broadband connectivity in your community? Could you find people that were willing to serve as care navigators in your community? And until the release of this value-based enterprise framework, it was really hard to get resources without raising kind of compliance red flags, without doing things like trying to place free resources in the community. So really what we saw prior to that was you had to kind of rely on grant programs. You had to rely on, like, I recall working on a program in Arkansas. Arkansas did a great job with their rural health communities. They had a really big grant program funded through the University of Arkansas to get these resources to those communities at a discounted rate. Well, now, you kind of open up the door to providers, including integrated delivery networks, to say, look, perhaps there are some of these rural communities that we want to keep within our network, but we don't want to go outright and employ the providers in this community. They want to be independent. They want to continue to practice medicine independently. Well, you can now use that value-based enterprise framework to form partnerships to help those providers get access to resources at a discounted rate. That's going to be a win-win all around, because a lot of these big IDNs are nonprofit organizations that furthers their mission, and it also kind of builds goodwill for the brand in terms of serving really underserved communities, which we've got pockets of those here in Colorado, as you will know.
Yeah. I think that, one of the things that sort of makes me optimistic about models like this and the sort of intersection with technology is you're at a moment where if you're a back if you're like an orthopod or back specialist, that there are physical therapy options like Hinge, which are, done, you can sort of do remotely. And so you can really sort of you have this incentive to do some care navigation, and then you also have this really cool, you have access to a much broader network of delivery options. And through the value-based enterprise system, you can kind of think a lot more creatively about how you build that network.
Yeah, absolutely. I mean, it's a really exciting time from a provider perspective. Exciting in both a good bad way, in terms of risk is being shifted to you, but the amount of technology out there that's delivering kind of clinically validated improved outcomes is great. I think big headlines now is United Health's kind of decision not to reimburse for RPM except in very specific type of categories. I find that the ASM model is kind of taking a little bit of a different approach, and saying, like, look, if RPM and CCM is able to deliver lower cost of care, that's going to benefit you in terms of the reimbursement that you receive as a provider. So this is a big kind of period of, I'd refer to it as experimentation, and I think technology has a huge role to play in terms of really, I think what the magic is going to be is identifying those providers that have patient pockets that really need access to those types of digital health solutions. So either they have a lack of access issue, or they simply do not rise to the level of needing to be treated procedurally or surgically, but they need a convenient resource to be able to provide care, and maybe they don't want to make the trek out to a PT, and they want to do it from the comfort of the home. They have more option in the form of, like, your Hands, your Swords, those types of companies. So I think it's there's winds pushing in both directions. So it's interesting to see how that will shake out, but it's definitely an interesting time. And like you said, there's definitely a lot of opportunity to get creative in a compliant manner. Anytime you mention getting creative to attorneys, that's not what they want to hear. But now we finally have a compliance tool that enables a little bit more of that
Yeah.
creativity.
That's great. Well, this has been super informative, and super helpful, and I'll be excited to catch up with you again soon as we start seeing this model roll out and start seeing providers in the wild doing stuff like this. Before we go, can you let folks who are watching or listening know where to find you and InHealth on the internet, or how they should get in touch with you?
Yes, absolutely. So you can go to our website, www.inhealthadvisors.com. You're welcome to email me. My first name, Luis at InHealthAdvisors.com. Showing that up on the screen just to make it easy for people to catch that. But always happy to talk, always happy to answer questions. This is a subject that we in our company are very passionate about. And so welcome any comments, questions, concerns that people might have.
Awesome. Well, I'll put that in the show notes. And yeah, thanks so much for your time. And we're already looking forward to having you back, Luis. Thanks.
Thanks, Martin.